Good afternoon and welcome to the Columbus Metropolitan Club. We're streaming live from the Boathouse at the Confluence Park, and we also have an audience here with us today, and we want to welcome all of you to our forum. My name's Jane Scott, and it is a privilege and an honor to serve as the President and CEO of the Columbus Metropolitan Club and to be able to welcome you here today. Today, the forum, Social Determinants of Health, is the first of many in a new series we're calling Optimal Health, presented by Nationwide Children's Hospital and OSU Wexner Medical Center, with additional support today from Hospice of Central Ohio. We are live streamed thanks to our live stream partners, WOSU Public Media, the Dispatch Media Group, WBNS 10 TV, and PNC. We'd also like to thank all of those of you who have purchased virtual seats for today's forum. We're really grateful for your support, and partly because of your support, we're able to continue live streaming and providing the programs to our whole community. Today, the CDC tells us the conditions in places where we live, learn, work, and play affect a wide range of health risks and life outcomes. We also know there are stark differences in measures of health between neighborhoods and ethnicities. When the social determinants of health are so important and so vastly different, how do we get health equality or equity? Please welcome CEO Impact Community Action, Bo Chilton. Bo, welcome, and it's okay for the audience to clap.
Thank you.
Chair of the Department of Family Medicine at OSU, Dr. Nwando Olayiwola. Close? Close, okay, I practiced that. And the Interim Director of Professional Development at the John Glenn College of Public Affairs at OSU, and the former Director of the Governor's Office of Health and Transformation, and our host, Greg Moody. Greg's going to make a few short comments to set the stage, and we'll lead the conversation. So, Greg, it's all yours. Thank you.
Thank you. Well, thank you. I've been looking forward to the Optimal Health series and its focus on social determinants of health, which I'll just briefly describe as an introduction to our panel. Where we live, work, and play affect our health. Differences across communities result in differences in health. And to improve health, we need to understand what causes those differences. Here you can see most health is not determined by clinical medicine. Genes and biology are important. For some, this is the most critical determinant of health. And of course, we want access to clinical care when it's needed, but mostly your health is determined before you see a doctor by your physical environment, your health behaviors, and social and economic conditions. The social determinants of health, this definition is from the World Health Organization, are the conditions where we are born, grow, live, work, and age. These circumstances are shaped by the systems that distribute money, power, and resources. Differences in the distribution of money, power, and resources are mostly responsible for unfair and avoidable differences in health status across communities. For example, in the next slide, if you live in Stowe, you can expect to live to almost 90. But in Franklinton, where we are now, life expectancy is 60 years. That's a difference of 30 years of life based on where you live in Ohio. The same is true closer to home. In the next slide, life expectancy in Bexley is 85 years, and the Near East is 67. 1 mile separating 18 years of life. In Grandview, life expectancy is almost 85, and the Hilltop is 65. 1 mile separating 20 years of life. Picture these communities, Bexley and Grandview, Near East and Hilltop, and you can see how the distribution of money, power, and resources impacts health outcomes. So the basic idea with the social determinants of health is that upstream, we can implement policies that improve conditions downstream for everyone. But clearly, something is wrong upstream because our downstream health consequences are severe. On nearly every measure, infant mortality, heart disease, cancer, homicide, Black people suffer worse health outcomes and always have. COVID-19 highlighted the real crisis in an important way. The virus attacks Black and white the same. Biologically, race doesn't matter. But it kills Black people at more than double the rate of white people because of other socially determined risks. For example, Black workers are more likely to be essential employees and required to work despite the risk. Black workers are less likely to have jobs that can be done remotely, and Black families are twice as likely to live in densely populated housing. Alongside these health risks, COVID-19 exposed other injustices. In Toledo, Columbus, and Cincinnati, Black people were 4 times as likely to be charged as whites for violating stay-at-home orders. And 40% of Black children received no instruction during the lockdown, compared to 10% of white. There is important work in this space to address social needs, linking individuals to safe housing, reliable transportation, good jobs, all of which improves health outcomes downstream. But the real issue is still further upstream. Again, the distribution of money, power, and resources is mostly responsible for differences in health status. Privilege in these areas, wealth, representation, education, flows downstream as opportunity and better health outcomes. And the legacy of slavery and segregation in these systems and current forms of racism flow downstream as hardships, disadvantages, and poor health outcomes. Reducing health disparities means rethinking the systems that distribute money, power, and resources, and eliminating any legacy of racism embedded within them. Franklin County and the city of Columbus were among the first to declare racism a public health crisis, and many others have followed. It's in that spirit of action and reflection that we turn to our discussion today. And I've got to say, I've been really looking forward to the conversation. Let me just kick it off by saying, where do we start? How have you seen, maybe setting the stage for us, how have you seen racism impact health?
Yeah, so thank you all for being here, and thank you for that great introduction. My name is Dr. Nwando Olayiwola. I'm the chair of the Department of Family and Community Medicine at The Ohio State University Wexner Medical Center. And I have the great fortune of having both medical training and public health training as well. And so I'll just start off with sharing some of my observations and experiences. And I'm very, very glad to see Franklin County and so many of the other cities and towns, not only here in Ohio, but across the nation, really start to actually explicitly call out racism as a social determinant of health and also as a public health crisis. So I'll speak mostly to the medical field, and my colleague, Bo, will speak more to community-related activities. So I want to just maybe set the stage and tell a quick story. I'm fortunate my husband and my 2 children are here today, and during the pregnancy of my second child, my daughter, I was enormously sick and just had a number of different complications throughout the course of that pregnancy. At the time, I was a busy executive. I was a chief medical officer of a large network of community health centers across the state of Connecticut, in fact, the largest one in the state of Connecticut. We had a great family, great home, living a very good life. And so when I started to seek care for some of the challenges that I was having during that pregnancy, I kept on getting pushed out of the system. And I remember vividly one of the times that I had been taken to the emergency room for some complications, some symptoms that I was experiencing during the pregnancy. The emergency room physician completely disrespected and disregarded me and said, I know how hard it must be for you as a single mom trying to make ends meet. And I had never said anything about my marital status, nothing about anything. And he said, but I think maybe you might just be a little bit anxious. I've seen this in a lot of women, and I just completely dismissed my symptoms. So I later ended up getting admitted to the hospital for a very serious problem during that pregnancy. And before I went upstairs to be admitted later, I had to push. I was saying, no, I've looked this up. It's very common to have pulmonary emboli earlier in the pregnancy. I don't understand why you're not working me up. I called my brother, who was also a physician, and had him talk to the physician. And finally, they took it seriously and ended up getting admitted. And I was there for a week. And before I went upstairs, I said to him, what made you make those assumptions about me? I had not said anything to you about anything related to my kind of socioeconomics or anything, but you just assumed a lot about me. And based on what you assumed, you disregarded me. And so when I think about that, and I think of those statistics that were shared, fortunately, my daughter's here. She's 10 years old. She's beautiful. The pregnancy went well, so I should say that part too, so people don't feel like it all was bad. But I had to fight really to be respected and for my concerns to be appreciated. And when I look at that staggering data that's shown up there about the infant mortality rate for Black women here in Ohio, one of the highest disparities in white and black infant mortalities in the country. I think about, that could have easily been us. And it wasn't really about, people say sometimes, well, the reason why we have those disparities is because of poverty, or is because of, low education, or people don't really understand how to work the healthcare system. Well, here I was, a very savvy healthcare consumer, socioeconomically fine, highly educated, and it still happened. And so what I take from that is that the biological construct that racism has been kind of perpetuated by is not really real. There's no real difference between the pain or the symptoms of a black pregnant woman and the pain or the symptoms of a white pregnant woman. And so if you take that away, all those other things, and you see that those disparities still persist. Serena Williams, with all her fame and money, still had enormous problems when she was accessing health care for her during her pregnancy. So it's really not about that. And that's why I'm really glad to see that we have actually called out explicitly this issue of racism, because we have been trained in health care to actually perpetuate some of the stereotypes that have been put on different communities. And if you're educated that way to be able to think like that, then when a woman like me walks in your door, it doesn't matter. I can have all the education, all the money in the world. A Serena Williams can walk in, and you'll still experience it. So I'm really glad to hear that we're calling it out, and we know that the results of that are very, very, very disastrous. So the cumulative stress of being an African American in this country, having police brutality, experiencing the toxic effects of anxiety, watching on the news and seeing the way the media portrays African Americans across the country, and knowing that, for me as a mother, as a wife, as a daughter, that any of my family members could be subject to any of these challenges at any time, and have been, and will be, and continue to be, that stress is a very common cause over time of premature death in our population. So when you see those disparities that are existing by zip code, this false construct of race that really has no biological meaning but has now been manifest in racism is part of the problem.
Dr. Nwando, thank you for that analysis. I just want to piggyback on something that you talked about. When we talk about opportunity, there is a database called the Opportunity Atlas that allows us to see the data based upon where people are born, and it has a determination on their life chances and their health outcomes. The idea that someone can grow up just a few blocks away from another and have such disparity and differences in their opportunities is quite amazing. If we think about, for African Americans in particular, since 1619, August of 1619 is when we have documented the beginning of the transatlantic slave trade. And for over 250 years, subjugated to chattel slavery, and then another 100 years of Jim Crow segregation, and then the fight for civil rights. When we think about trauma, now we talk about trauma-informed care, and how we don't want to ask, well, what's wrong with someone, but we want to ask what has happened to this person. And so when we think about the trauma, generational trauma from slavery through all of that subjugation and oppression, and how that manifests today in behaviors and differences in outcomes, of course we understand the importance of how that trauma impacts our mental health. And so for me, it's about understanding how do we achieve equity versus equality. And so the difference that I would draw there is to treat someone equal is to treat them the same. But what we need to understand is that in order to have equity, then we have to have, using the example, if you say that you want to treat everyone equal, everyone is given a pair of shoes. If we want to treat everyone equitably, everyone is given a pair of shoes that fit. So we do need to have stratified care based upon the specific needs of the population that we're serving. You know, for us to say that we're colorblind and that we don't see race, that's not benefiting me. I want you to see me as a black man and understand that I have specific challenges and that I have certain privileges being a male, or there are certain privileges that come with being white or being light-skinned black male. Acknowledging those privileges is critically important. And then us seeing people and really understanding how do we create an equitable society. And that means seeing one another, and that means hearing one another. If anything we've learned that has come out of the unfortunate tragedy of George Floyd's death is that we need to wake up, see what's happening, and we need to listen, because riot is the language of the unheard. That was said by Martin Luther King Jr., that riot is the language of the unheard. And so now I feel like as though we are seeing and we are hearing, and now we need to get beyond the dialogue and move to action.
Thank you. Yeah, I was even reflecting on our discussion of social determinants, and 3 months ago, how far we might have taken this conversation. And then COVID draws attention to disparities in a way that push a little further. And then I think the killing of George Floyd finally calls it what it is in terms of looking head-on at elements of the system. But that embedded nature, that's hard to get at. Moving from dialogue to action, what are some of the things you see as being constructive for us to take on? What are the things we can do to start kind of undoing what's been built in for so long?
Yeah, I'll go first. One of the things that I alluded to earlier was the fact that, speaking from kind of the medical field and the establishment and the way that we are trained and educated in medicine, is that we are trained to socially categorize people in ways that continue to perpetuate and allow certain stereotypes to live. So, for example, when I was in medical school, I was taught that African Americans had a higher pain tolerance. And so, therefore, when I was in the emergency department and African Americans with sickle cell pain or other sorts of chronic pain would come in, it was okay to not really validate or believe that pain, because they can take a lot more. And that really has its origin in the slavery days, when it was thought that African Americans, blacks could tolerate more whippings, more beatings, and would not have any problems with that. I've also seen this happen where symptoms are minimized. And so when, African-American women like me, as many of you know, are often very much stereotyped as being angry or being aggressive or being overly anxious. And so when you come in and when you are being trained to take care of women from that background, it happens a lot with Latina women as well. The thought is that, well, they're just a little bit more anxious and hysterical, so you can just ignore those things. And so one of the challenges that I see is that the way we educate physicians and nurses and other healthcare providers is to start to embed those stereotypes into them very early, so that when they're practicing, it's no surprise that they see us in the emergency room and they think, oh, probably not a serious thing. So one of the things that I think is hugely important is that we have to really honestly deconstruct and reconstruct medical and health profession education, because students are learning things that are really not based in science. And I remember when I was a resident, I did my residency at Columbia, New York, and I remember being on rounds, and we'd always have to say, so-and-so is a 45-year-old black man with this and that. And one day, someone on round said, why do we always have to say what color they are? Does it matter for this particular context? And if it does, then fine. But if it doesn't, then why are you making us do that? And so I think that there's a lot we have to do to really rebuild the way we educate the people that are going to ultimately take care of all of us some way or some time in our lives.
Yeah, it certainly starts with education. I'll give an example of a person I know around my age. His father fought in the Vietnam War, was a soldier, and unlike some of his counterparts at the time, was not able to take full advantage of all of the amenities afforded to soldiers at that time, including the GI Bill, loans for veterans. He grew up in the same house that his family grew up in. And we can look at, I'm often asked the question, are these issues really based on race, or is it more socioeconomic status? And what we have to really talk about is the intersection of race and poverty. And so the guy I'm thinking of is a perfect example of how racism, systemic racism, it's built in. We don't even notice it hardly. It's built in how racism actually perpetuated the lower socioeconomic status. And so this young man grew up in the same household that his family grew up in and is now raising a third generation in that same household. They live in a neighborhood that has been dilapidated for a while with a lot of flight from that neighborhood. A lot of that policy then for home ownership was based upon redlining. So again, this is where systemic racism comes in and has an economic impact. And so based upon him raising his children in that particular house, third generation that grew up in that house, their opportunities are limited. The neighborhood schools are not strong. And so the work opportunities are not strong. This gentleman ended up selling drugs to make money, was eventually arrested. The terms of the arrest were a bit murky. We believe there were racial profiling at play. Not to say that he was not guilty, but the circumstance by which he was pulled over was murky at best. Again, possible racism based upon racial profiling. Because of systemic policies or because of governmental policies which had heavier weight for crack cocaine versus powder cocaine, this person basically served almost 20 years of his life. Now that household grows up without a father. And again, we talk about, was this racism or was this basically poverty? And what I would say is it's the intersection of both. One contributes to the other. So what we need to do is have truth and reconciliation in our educational system. Unfortunately, much of what we've been told, at least when I was growing up, I hope it's different now, is more of the truth. Just now we're starting to see a lot of monuments come down from the Confederacy and the story that we've been told about Columbus and who he was and how he discovered America. See, now we're starting to uncover the truth. And so I think that in order for us to have peace and prosperity for all, we have to have truth and reconciliation. And that starts with educating our young people. And I'm glad to see that a lot of young people are asking their parents some very tough questions about why have I not learned this history and this truth before. So I think it starts there.
You've both made a decision to provide your own personal leadership. Dr. Olayiwola, you are on the front lines of the consequences of downstream health problems. And Mr. Chilton, you're in the community trying to connect to transportation and housing and those social needs people have. From that viewpoint, where do you find the most encouragement? Where do you see things changing in the way, either over time or very recently, that you feel are really going to get the kind of traction that's needed? Where do you see that leadership emerging? And partly I ask for us listening, where can we attach our efforts to support the type of leadership that's going to be required to bring about real change?
So for me, I mean, I think I've been really happy. I mean, I joined the Wexner Medical Center just a few months ago. So I came back to Columbus after being gone for almost 20 years to be chair of the department. And I've been really, really happy to see some of the efforts that have been going on around diversity, equity, inclusion before all this kind of blew up, but certainly the ongoing kind of encouragement and intention around making sure that we were addressing some of these issues. One thing that I think that is very important, I mean, if you think about African Americans, we make about 12-13% of the population. But when you get to higher levels of leadership for faculty, senior leadership in medical centers, academic institutions across the nation, you see those numbers drop significantly to, maybe 2-3%. And I think that we have to be really thoughtful about making sure that we're building the pipeline and making sure that we know that structurally, as Bo mentioned, and systemically, it's very, very hard for people of color in general to advance in the health professions and to be promoted into senior leadership positions, to be mentored so that they can succeed. But we know that that starts much earlier in the pipeline, right? So, this is not like all of a sudden you get to medical school residency education and then these problems occur. These are problems that are happening because of the failings of our schools and the educational system. But I do think that being able to really actively say the word racism, like actually say that, and recognize that as a contributing factor to how historically African Americans have been suppressed and oppressed in medicine from where I sit is really, really important. I've really been happy to see our chancellor, President Drake, be able to actually call those things out and do that so that we can start moving towards dialogue. And so we've just announced an anti-racism action plan that our medical center is going to be undertaking, where we're going to be looking at a number of different policies through kind of an anti-racism lens. We're going to be looking at our education, looking at how we advance faculty and staff and how we create opportunities for people to grow, looking at how do we relate to our communities and what kind of investments are we making to make sure that the communities around us are thriving and that we can mitigate some of the disparities that we're seeing. So I feel pretty hopeful that we are going to make real change because we have leaders from diverse backgrounds who care about these issues and are going to push it forward, and I think that's really important. We also have a lot of momentum that's been given at the highest levels of leadership. And then, honestly, we have communities that are ready and waiting for us to do something. So I think those things all combined put us in a position where I think we'll move forward this time.
I'm most encouraged by the broad cross-section of support. 4 years ago when the statement was made, Black Lives Matter, that became a very polarizing statement in our community, and a lot of pushback that said, well, all lives matter. I think now the circumstances have shifted where now I see a lot of people who are not Black who are saying Black Lives Matter. And of course, all lives matter, but that was never in question. There was a question about whether Black lives matter to America, based upon slavery, based upon the fact that when someone is stopped, we don't hear about other ethnicities and races being killed. We hear about Black people, Black men in particular. And so that was a question. Black Lives Matter, it's an affirmation among Black people who felt as though our lives did not matter. But now I see a broad cross-section of people who are saying, yes, Black lives do matter, as do all lives. I'm most encouraged by the young people. There's a lot of energy and excitement, and so now I want to turn that passion and that protest into a plan. And so we're working with young people. I'm very excited about our partnership with the Social Change Department at Ohio State, and so that's something I want to connect with you on, Dr. Nwando. I'm very excited, though, about the energy that I'm seeing with the young people and getting out to vote, but not only having voter registration, but voter education, talking about civic engagement. And I believe that we, as adults, need to put our money where our mouth is. We can't just let the protest voice be out in the street. It needs to come into the decision-making arenas and tables. On my board, I have millennials. We have a 21-member board. 7 of those seats are democratically elected. We have community elections, and we had a young person who was 25 and decided she wanted to run. She ran and she won. And so she has a voice on the governing body of my nonprofit. She has influence in determining how our resources are going to be allocated and making sure that they're allocated for all people in our community. And so I'm most encouraged about the young people and the energy and the excitement, and this feels very different than times in the past. The thing I would liken it to is the energy and momentum that I saw coming out of the civil rights movement, particularly once We had the image of Emmett Till burning in the brain of Rosa Parks as she sat down on that bus and launched the Montgomery bus boycott. It was the symbolism of that imagery that really fueled that movement. And so George Floyd and Breonna Taylor and Ahmaud Arbery, all of those, that trio of incidents that people have witnessed and no longer dismiss the pain and the stories of people who have said, I have suffered this oppression, this subjugation. This has been my real experience. It's opened the door to conversations with people to ask, well, what has been your experience, and for people to share. So it's the open communication and it's the young people that has me very encouraged and excited about the future.
Can I just add one thing to that? Because as Bill was talking, I was thinking about something that I've also noticed and have really appreciated, which is that I think that for a long time, many white people did not feel horror when they would see the killing or, the brutality against a Black young man or woman on TV. Like, it was just like another thing that you see in the news and you kind of continue past it. And what I've been seeing now is that people are actually saying, I'm horrified by seeing this. Because if you don't fundamentally think that the life of my son is worth the life of his son, then you will never be horrified when you see someone brutalizing my son on TV, right? You would never be. So I think for people to start to feel that horror and say, like, that could actually be, that's someone's child, that's someone's brother, that's someone's son, that's someone's mother, or that's someone's sister. Like, if and to actually internalize that and think as a human, like, this is horrific. I've been really happy to see that people are starting to see that. It's not just kind of these things that we've been indoctrinated to see in the media all the time that seem like, it's these people of color over there, and that's not me, it's not anyone in my family, but actually seeing that and saying that that could be anybody that I know, and this is absolutely horrific. And I feel like I have not seen that until recently, and now I'm really happy to see that people are actually recognizing and putting themselves kind of in the places of people that are going through these experiences and trying to learn empathy around it.
So in just a few minutes, we're going to open it up for questions. Live audience questions here are welcome, and also folks on the live stream, you have an ability to send your questions in. We're looking forward to that. I appreciate your talking about the call to action for young people, and I hope this doesn't put you on the spot too much, but my son's here. Nwando, I know your children are here. Bo, I know you have children. What do you say to them? To speak to them kind of in this moment, what is the encouragement you offer to that generation? And in addition to the call to action, do something. What is the encouragement you provide?
I mean, for my kids, we've had a number of different conversations about everything that's been going on, and have been, I've been challenged by some of the things that they've asked me, because they just don't fundamentally understand why we are the way we are, and it's kind of bizarre for them to think that we treat people differently because of the color of their skin. I don't think that they really fully understand why that is. I've also had to talk to them a lot about fear of police and being brutalized by the police, and there are countless stories of kids, and particularly children in my family and some of my nephews, and who have been just terrified by what's going to happen if I go out. I've got to be there, and I've also become a lot more protective of them. Like, no, you can't ride your skateboard around the corner just because I need to make sure that you get back, or if you do go, have this thing on you so I can track you and know where you are. So I think what I'd say to them, because they're smarter than us. The generation behind me is much better and more aggressive, and the millennials are just so passionate and inclusive in ways that I think generations before them have not been. So what I'd say to them is just, keep speaking your truth. Be you. Don't let us mess you up, right? Because you came in and you've got really good ideals and values, and you believe in a world that we have not created for you yet. And so just keep fighting for that, and don't let us mess you up. That's my advice.
I agree with that. I am not naive. I have spent 13 years as a CEO of a poverty-fighting organization, and we've seen a lot of trauma, and we've seen a lot of positive, hope-inspiring stories. The thing that I agree with you is let's just not mess them up. To the young people, keep asking those questions. Stay curious. You know, I had my son once tell me, he said, well, Dad, you know, some of the problems that you're describing sound like old people problems. I don't have those issues with my friends. And so I said, well, you know, we'll see. I said, but keep having honest conversations. They're actually talking about these things. And you don't have to have it all figured out. There's no blueprint to how we navigate the future. But keep pressing, keep asking those questions, keep reading, keep being curious. And I think that together, this generation will help us solve some of our most intractable problems. And you will be the ones who inherit whatever needs to happen with climate change and global warming. And so you need to stay at the table and push to be at the table to make those decisions.
I'll ask you for one last closing thought, but it occurs to me too that this coming generation has tools that are new and very powerful too. Being able to witness history as it's happening and share that and communicate that. There are tools now that I think may be difficult for an older generation, but it's just natural, and it's the way things are for the new generation. One thing I'd say too, last week, the Metropolitan Club hosted a conversation with young black men. There's going to be a conversation with young black women. I would encourage everybody to go back and hit that link and watch that, because in terms of being encouraged about handing off decisions to a next generation, all you have to do is watch a few minutes of that, and you can feel really secure that we're headed in a good direction. Any final thought as we move into questions?
Yeah, I mean, my final thought is just that for everyone to take away is really just, you know, think about the value that you place on life and on opportunity. And if you can just retool a little bit of how you've been socialized or indoctrinated and unlearn some of the things that you've learned already, and the false narratives that you may have been taught at a very young age and have kind of continued to have throughout your life. If you can do that and just decide, and again, I'll leave you with this because I think it's really important to me, you know, as a mother, that if you can leave and believe that the value and opportunities of the life of my two children are the same as, should be the same as the value you place on the life and the opportunities that you provide to someone else's children because they're non-black and they're white. If you can believe that, and you can actually believe that, and see those as those, I don't care where they're from, I don't care what they look like, they should have the exact same opportunities, and they should have opportunities that are equitable, so maybe even more opportunities created because of the disadvantage or the vulnerabilities that have been placed upon them. If you can see that and you can believe that and you can imbibe that, then I think that we can go a long way in making this world and this country, and particularly this state, a better place.
I will say for those that are ready for action, in particular the young people and people in this community, I encourage you to check our website to get involved. We will have a robust voter education and civic engagement program. We want to look at policy, things that if we really want to make sure that we have an equitable society, we got to pay attention to what's happening to the Community Reinvestment Act and the reforms that are being proposed. It will be devastating to communities and erase a lot of the progress that has been made. So those are specific policies that we need to pay closer attention to. There's a lot happening now around criminal justice reform and civilian review boards. And so I'll be involved in that work locally and definitely want to get some young people connected to that. And then finally, I'm going to say this. As we talk about social determinants of health, we have to look at the wealth disparity. The inequity continues to grow, and it's just not sustainable. If we look throughout history, this type of disparity and inequity is just not sustainable. We have to find a way to have shared prosperity. And part of that means corporations paying their fair share of taxes. It's going to take resources for us to repair some of the damage that has been done. And the only way that we're going to be able to do that is if everyone pays their fair share and we have equity. So those are the types of policies and advocacy issues that we need to be engaged with.
And that kind of is the final word on our social determinants around money, power, and resources really being kind of the determinant factors ultimately of where we need to bring about the change. So at this point, it's the CMC's tradition to take audience questions. Jane Scott, CMC's president, is curating questions from the live stream audience. If you're here in our audience, please remember to keep your microphone time to the question, and we thank you for avoiding editorial comments. But Jane, I'll look to you for the first question.
Wonderful. I have about I have about 5 questions. Eric Jenkins from Dedicated Senior Medical Center asks, what is your position on value-based care?
Yeah,
And I don't know what that is, but.
Yeah, well, value-based care is basically reforming the way we pay for care. So in the United States, we have a fee-for-service model where the hospital, the doctor is paid for seeing you. And so the incentive is for you to continue to see people and maybe see them when you don't necessarily have to as much, so that you get paid. So the fee is for the service actually being provided. In value-based care models, what you're looking at is you're paying for value and you're paying for outcomes and you're paying for quality. And so as you think about, I'm not paid because I had 20 visits. I'm paid because the visits that I had, I took really good care of those patients and provided really good quality care. So I think value-based care is a really good way to start to think about how do you allow for kind of equitable delivery of care and assign responsibility to people for being able to provide high quality care to people regardless. And so if we were in a value-based model, some of the things I talked about may not have fully happened because you'd be really incentivized to take good care of me. So I'm a big fan. I think we have a long way to go before the United States will shift to full value-based care, but thank you for that question.
I want to piggyback on that. I don't know much about value-based care, but I do know about affordable health care, and I want to advocate for that. We're the only industrialized nation that does not have a public health system. It's based upon our employment, and that it's crazy that we spend almost 17% of our GDP and have some of the poorest outcomes, health outcomes among the industrialized nations. So it's time for change there.
And actually, just to piggyback on that, because when you look at the industrialized nations, we also have not just poor clinical outcomes, we have poor access, efficiency, and equity outcomes compared to the kind of the main 11 industrialized nations that we're usually compared to. So we're spending a lot, but we're not getting a whole lot out of it.
Good afternoon. My name is Carla Hicks, and it's been researched that the disparity, a lot of it that exists in the social determinants of health, are rooted in policy and legislation. And Bo mentioned a few. My question is, are there younger groups, stakeholders, who are looking at policy and legislation? We have House Bill 620 that's proposed by Representative Erica Crawley. And the proposal is to look at all legislation that's proposed through a health and equity lens. So is there a way that we can get younger people involved in helping to see things move through the legislature?
So I'll say I'm familiar with Representative Crawley. I was not familiar with that bill, but that's something that I want to get our young people and the people that we're working with now involved in. I like the idea of looking at all legislation through the equity lens.
Yeah, I agree. I don't know where it's being done well, but I do know that it's very important to do it. And it's one of the things that we're actually committing to is that every single policy, hiring, promotion, admission, community partnerships, vendor relationships, selecting patients to be part of our patient advisory councils, all those things are going to be looked at through what we're calling the anti-racist health equity lens. So hopefully we'll figure out how to do it and do it well, but I agree that it's very important that we do.
Thank you.
This question is from Emily Preto. How will development/gentrification in inner city impact healthcare and services in 5, 10, 15 years?
Dr. Nwando.
Since it's defer to you. So, well, I think that only, as you saw on the slide, a very small fraction of anybody's health and wellness comes from them seeing me in the office, right? So like, if I don't, fantasize that, my role as a doctor in the office with a patient is the most important thing to their health and their life. I know that that's very much not true. I know that the things that will determine their health and their life expectancy are things like blight and violence in their community and poor educational structures and ongoing systemic racist practices and policies. And so as you continue to shift people further and further to poverty, which is what gentrification often does, you move people out of places of comfort and for whatever type of industrialization or, advancements that you're looking at, and they continue to move to places where they become either they move into homelessness or they get transitioned into unstable or inconsistent housing. It's almost impossible that that can be good for their health. So as we see more and more gentrification, communities pushed out, people put on the brink of homelessness or put in, unstable housing conditions or crowded community housing conditions, we will undoubtedly see worsening of people's health because most of their life is really dictated by those other things and not that office.
I'll just add, because we showed the specific example on the slide with the difference in the age of someone in Franklinton versus Dublin. I think the number was 60 to 89, something of that nature. Well, recently we had a hospital close down shop on the west side and relocate a brand new facility south of Columbus. And, for a lot of different reasons, but if we already have a significant problem with the life chances of someone living on the west side, and now we no longer have adequate health care being provided on the west side, I mean, it's pretty easy to understand what's going to happen. Those cycles of inadequate care will continue to be perpetuated.
And just like the suggestion for equity in all policies, in healthcare, there's a corollary where you can have healthcare in all policies. So as you're looking at transportation and housing and community development, do you have a lens of how that's either taking you closer to better health outcomes or keeping you away? And so that's a discipline in all policies. Next question.
For people who look like me, there seems to be two issues dealing with health care. One, as you mentioned, Bo, is the issue of access. I mean, how do we get health care? Do we have insurance? But the other issue that often doesn't get talked about is the quality of health care. You mentioned already that in many industrialized countries, the outcomes are better than America, even though we pay more. And so the question I want to ask the panel is, how would you define quality health care? I'll just say, I've had insurance all my life, but it wasn't until November where I changed my provider. I have my physician's cell phone number. My doctor's office calls every week. I can get groceries and all this stuff. So I'm finding out there's a difference. And so I guess I want to know from the panel is how would you define what quality health care means?
That's a great question. I'm glad that you've got a provider now that is giving you that kind of attention. One of the failures, and I've written about this, some of my research has looked at this, is around quality improvement in healthcare has been that a lot of times, and I think when you go back to Bo's analogy of the shoes, you just give everybody a pair of shoes and that's a quality, but you give them the shoes that fit, that's equity. What we've done in quality improvement is we've tried to kind of raise the level of quality. So we're going to take on a massive hypertension improvement project, and we're just going to hopefully reduce people's blood pressures. Well, when you do that, what we've seen is that, globally you might improve your outcomes, but you've widened disparities because you have not necessarily tailored the interventions that are necessary to the communities and that needed and experienced kind of their hypertension differently. So one of the things that I think is really true high quality care is having a personal kind of lasting, reflective relationship with whoever that physician or care provider is, where you are listened to and you are heard. I cannot even tell you how many times I get patients that come to me and say, wow, I'm so glad you're listening to me. You're listening to me. And I think that we have to train our upcoming generation of professionals to really listen, learn, empathize, right? You may not understand all of those things, and try to avoid judgment and all the things that happen. I heard a story the other day about people, assumptions that are made basically in the first 10 seconds of meeting or interacting with a patient essentially dictate the way you'll give care to them for the rest of the time that you have them. So being able to train people to really understand how do you deliver empathetic care, meet somebody where they are, and listen more than we talk. I think doctors, we talk a lot, and we don't listen enough. And then when we do listen, we still hear what we thought we wanted to hear. So I think high quality care is listening, empathizing, building those relationships, understanding that every single person is a person, and they're not necessarily, I cannot make any assumptions about you based on the community that you come from or where you live, and trying to make sure that we deliver care to meet your needs.
I couldn't say it any better.
I'm Brian McMichael. I'm from the OSU Medical Center. One of the things that I confronted, I actually came late to medicine, and I actually bought my first house not too long ago in Woodland Park. But one of the things I noticed that I think needs to be dismantled that has to do with a whole kind of racket, that housing prices have to do with resale value, that have to do with good schools, that have to do with property, local property taxes, funding schools into this kind of spiraling opportunity hoarding versus a downward spiral in, educational opportunities, infrastructure. It seems to me that, this is a racket where people have, they have skin in the game, where if we dismantle that, it's going to hurt, resale values. If we say we fund education differently. Do you ever think about that, about how that would affect communities and even access to health care and overall health in communities?
So, mentioning the way in which our public school systems are funded, there's a state allocation that each school district receives, and then they're funded by property taxes. So obviously in more affluent areas, they're going to have more resources to educate their children. That's already been proven to be unlawful, but we have not figured out the solution. I'm going to add to that when we have major developments in certain neighborhoods, we have to be very careful with our tax abatement policy as well, because it deprives our school systems of much needed resources in order to educate our children. And so, again, I'm going back to policy reform. We need to look at our tax abatement process. We need to look at how we're appraising homes and what's occurring there in terms of gentrification, particularly for a lot of our seniors. And so this goes down a whole nother road. But yes, we need to find a way to equitably educate our children across the public school system.
Yeah, no, I agree.
Well, thank you, speakers. I heard words today such as anxiety, generational trauma, the intersection of race and poverty, the distribution of money, power, and resources. I think there's going to be some other conversations we're going to be having about some of those kinds of things. We'd also like to welcome you back. As Greg said, young Black women will be taking the stage on July 15 to share their perspectives. And if you have not seen the forum last week, I also would echo Greg. It was very powerful. These young men were just brilliant, and I would really encourage you to go back and take a look at it. And we hope you'll tune in next Wednesday at noon online, or join us here in the room at the Boathouse as we continue this series, Racism, Where Do We Go From Here, with a discussion about media bias. We'll have 3 journalists on stage next week. Thanks to our Optimal Care Series presenters, OSU Wexner Medical Center and Nationwide Children's Hospital. And thanks today to Hospice of Central Ohio for your additional support. And we're also grateful for our live stream partners, OSU Public Media, WBNS 10 TV, PNC, and the Dispatch Media Group, and to all of you who purchased virtual seats. Thank you. Thank you for helping us keep the conversation going. And finally, special thanks to our speakers, Bo Chilton, Dr. Nwando Olayiwola. Close. All right, we'll get it. Yeah, and Greg Moody. Thank you so much, and we hope to see you all again. In the meantime, be well and stay safe. Thank you.